So, this is one program which all of us have been waiting for. This is the future of ophthalmology, the teachers of tomorrow. So, we have with us 12 very, very enthusiastic kids who are going to mesmerize us with their teaching. 12 topics in the next 90 minutes, which will actually mesmerize us significantly. So, first of all, let me talk about the rules of the game. So each of the teams, we had actually teams from multiple centers, all the states of India, and we have selected two from each of the semifinals. And so we have in total 6 people in this particular group. And before we go in, I would tell you that each of them have been given with one topic yesterday night at 12 o'clock. After the program was over, yesterday night at 12 o'clock, they have been given a topic. And they have prepared it through the night and is out here to talk to us about that. And in 4 minutes, they will be teaching us. They will not be presenting, but they will be teaching. And the judges will be evaluating the teaching of these children. They are not evaluating the content, they will not be evaluating the style, but they will be evaluating the overall teaching, the use of all the teaching equipments, all the teaching abilities, their philosophies in teaching, their interaction, their eye contact, their presence in the stage, their use of accessories, their questioning ability, their retaliatory abilities. These are the things uh, which will be evaluated by the kingpin of teachers in India. These judges, you should understand, are the real big teachers of India who have been teaching for over 3 or 4 decades. Let me invite, first of all, Dr. J.S. Tityal. Tityal, sir. He is Chief of RP Center. Tityal, sir, is here. Okay. Dr. Mahesh P. Shanmugam, sir. He is the program director of Retina Shankara Eye Center, Bangalore. Reshmin Gandhi. You can, yeah. You can sit there also. You are the students, sir. You are the students. So they will be teaching you. Yeah, they may punish you also. I don't know. Imposition. Yeah. Yeah, please. Yeah. Dr. Chityal. Yeah. Uh, Dr. Krishna Prasad R is not here, I suppose. Dr. Pandav? Dr. Pandav? Okay. So I will call in the teams one by one. I will just introduce the teams. So from Assam, we have, I think the TOT can come right up in the front and sit here. From Assam, we have Rutusha Dodwad, who will be presenting to us on Jackson's core cylinder. Dr. Gargi Vavikar on stereopsis. From Chandigarh, we have Hitisha Mittal, who will be presenting on anti-VEGF in PDR. Dr. Abha Gupta, topography in keratoconus. You can all come up front and sit here so that, yeah. And from Tamil Nadu, we have Dr. Samir Chowdhury. Tamil Nadu, we have Dr. Samir Chowdhury, who will talk to us on OCT biomarkers of AMD. Dr. Deepika on lateral orbitotomy. From Telangana, we will have Dr. Anirudh Harur talking on subluxated crystalline lens. Dr. Prapi Chedda on high myopia. From Chhattisgarh, we have Sanskriti Tiwari on cell therapy and Yamini on gonioscopy techniques. Maharashtra, Dr. Ankita on failed trabeculectomies and Neelambika Kulkarni on newer techniques for population-based screening. So let's have the first. So what Dr. Tityal and Dr. Pandav? Yeah, KP, I think KP is not there because KP's daughter is getting married. Yeah. Please, please. Dr. Krishnadas, sir, you are welcome to join us. One of the teachers who would be getting taught today on the. Sir, you can sit there. Yeah. So from Assam, Rutusha Dodwad, you can come up here. What is the status of the remaining judges? Pandav sir and Tityal sir? Did you call? The timing is 4 minutes. Audio video team. The timing is 4 minutes. 4 minutes is the timing. And 2 minutes interaction, question, something like that. Like you can ask them doubts because you're students. And we will give you Abhishek. No, who is, yeah. Which one PPT?
This is not mine. Mine is Jackson's cross cylinder, Rutusha Dodwad, and this one. मुझे बस हैंड माइक पे दे दीजिएगा. ये हमारी मेरी है. हैंड माइक चाहिए. Hello. This is also walking. हाँ ठीक है, but I think I'll walk also ना बीच में. थोड़ा अगर मैं दूर चली गई तो. हाँ दे दो.
So from Team Assam, who is the next person who can be here in this podium?
चेंज नहीं करेंगे स्लाइड ऐसे इससे. The space bar I should press?
Next arrow.
Arrow. Okay.
अभी तक बैठो सेकंड है ना
Dr. Gargi Valikar, मुझे भी hand mic लगा. It's not the Gargi Valikar. Hand mic लगी वाली ये वाली. Slide changes.
Okay, so let the first person start. Dr. Rutusha.
Yes.
Start.
Good morning, students. Rise and shine. Today we are going to study about Jackson cross cylinder. I would like to thank Dr. Kasturi Bhattacharjee for being my mentor for this session. A lot of my students ask me, "Ma'am, how many cases will we get? How much cataract do we get? How much refractive procedures do we get?" But all of this is not going to make any sense if you do not know how to do a proper refraction, how to give a patient a 6/6 vision. So I suggest you learn about the Jackson's cross cylinder because it helps to refine the astigmatic refraction by fine-tuning the axis as well as the power. Coming to understand the Jackson's cross cylinder, the parts, it is basically two equivalent cylinders which are arranged at 90 degrees to each other. The white line representing the positive axis and the red line representing the negative axis. Note that the handle of the cylinder is at a 45-degree angle from the principal meridians here. We are going to take baby steps into understanding how to do a refraction and where the Jackson cross cylinder comes in. First, we always do an objective refraction, then a monoocular sphere estimation, and then a cylinder estimation. And here comes the role of a Jackson's cross cylinder. And as I have told you, today we are going to play a game. There are two levels to this game. First, we will assess the axis with the help of Jackson's cross cylinder, and second, we'll assess the power with the help of a Jackson's cross cylinder. Here I have an example. I want you to remember this, that the cylinder here is a minus, magnitude 1, and an angle of 180 degrees. We ask if the patient is able to see with this lens in the tile frame. If a patient is able to see a 6:9 vision, we ask him to focus 2 or 3 lines above. So we'll ask him to focus at 6:18 here. We'll place the Jackson's cross cylinder and pay attention to this, that the axis of the cylinder in the trial frame was 180 degree. Come on everybody, tell me what was the axis here? 180, yes. That we'll put parallel to the handle of the Jackson's cross cylinder. And after this, we'll flip the Jackson's cross cylinder and see and ask the patient if there is any change in the vision of the patient. There are two outcomes here. The patient will say that on both times, there was no change. Both of them were same. Congratulations to you, because you have crossed level 1. You have analyzed the axis correctly for this patient. The second is going to be where the patient says that the second one or the first one was better. So here, since the cylinder determined for this patient initially was a -1, so we move the cylinder on the trial frame 10 degrees downwards towards the minus axis. So what is the equivalent that we will be getting? 180 minus a 10 will be a 170, correct? To confirm this axis, we will again flip the Jackson's cross cylinder. The patient at the end of this will say that he will have both, on flipping the Jackson's cross cylinder, both of them visions were same. So here we have reached the equilibrium and crossed our stage 1. So congratulations guys, our axis is determined here. Moving to the second level of our game, determining the power. And we'll gradually increase our Jackson's cross cylinder power, start with a 0.25 and keep on increasing 0.5 and 0.75 thereon. Here important to note is we have obtained our axis. What was our axis that we confirmed on the previous level, guys? 170, exactly. So here our axis on the trial frame is 170. We'll make sure that our principal meridian aligns at a 170 degrees parallel to the one on the trial frame. We'll again flip the Jackson's cross cylinder and ask the patient if he was seeing any difference or was it the same. First outcome, he says same in both. So we have confirmed our power as well, which was -1 initially, and now also it is a -1 only. If the patient says that he sees better with a minus cylinder on the axis, we do an algebraic sum. An algebraic sum of what? The power and sign on the Jackson's cross axis and the cylinder. What was our cylinder power initially? A -1. And what is the Jackson's cross cylinder power that we used? A 0.25 and minus, correct? So when we do an algebraic sum, we get a -1.25 cylinder. Axis already confirmed was 160. Great guys, you're doing great. Come on, I want more interaction here. What if the patient was seeing better with a plus? How will we do the algebraic sum here? Original cylinder was a -1. The Jackson's cross cylinder we used was a plus 0.25. The algebraic sum coming up to -0.75. So guys, you have reached level 2, achieved level 2. A small trick here. What if you keep changing the power and realize that the dioptric power is increasing more than 0.5? What will you do then? Isn't it a nice question, guys? I want you to go back home and find out. Tell me in the next class.
Rutusha,
Good.
your time is already up.
Okay, sir. Okay. Thank you. I hope you learned. And I want you all to come back in my next class as you have come back today here again to listen to me. Thank you.
Ma'am, one question. Ma'am, if what patient's vision is 6 by 60. Can we still do Jackson's cross cylinder? We cannot do it.
Sir, we can if the patient has a refractive error, but we'll have to change the power from which we start the Jackson's cross cylinder power.
No, sir. I think one person can be asked by one student. I think something like that, so that we can put the marks. So for Ritusha, how much would the marks be? Can you show? Can we show the judge one would be 8, and judge 2 would be 6, and judge 3 would be 8, 6, and 8. All right. Now let's have Gargi here.
Thank you.
Gargi is here. She's presenting from here, right? Yeah.
Excuse me.
The next people from Chandigarh can be ready. Yeah, you are ready. All right. We have to stick to time. Winston Churchill once said that if you have to talk for 60 minutes, I can do it today. But if it's about 5 minutes, then I need 2 weeks to prepare. We are doing in 4 minutes, and we have given you some 6 hours. But you have to stick to time of 4 minutes, because that will be negative marking otherwise.
So, a very good afternoon to my students. I would first like to thank Dr. Kasturi Bhattacharjee madam for giving me this opportunity. So today we are going to learn about stereopsis. So what can you see in this picture? We can see a majestic eagle and we can see a timid rabbit. So this rabbit will need a very good field of vision to escape its prey. But what this eagle is going to need, it's going to need an excellent stereopsis and a very good localization to catch its prey. Now, we might not need a stereopsis as good as this eagle, but we definitely need a good stereopsis for everyday activities like climbing the stairs, and of course, we are surgeons, so we do need good stereopsis. So, binocular vision goes through 3 grades. The first is simultaneous perception, followed by fusion, and then we have the stereopsis. So, can one of the students tell me the definition of stereopsis? So, stereopsis is the visual appreciation of 3 dimensions during binocular vision. And for stereopsis to happen, we need to see that the retinal image has corresponding points in both the eyes as well as non-corresponding points in both the eyes. So the image has to be presented to both the eyes at a slightly different angle. So cortical neurons with receptive fields in both the eyes will integrate this information and they'll give us a depth of perception. Now here we can see that point F is foveally fixated in both eyes. Point T has it has non-corresponding retinal points. So now we can see the red graph that you can see, it is the cortical neurons receptive field. In picture A, we can see that the receptive fields look identical, but their positions are different, which is called as a position difference binocular disparity. Whereas in picture 2, they have similar position, but then their phase or their configuration is different, which we call as phase difference. Now we need to understand what a horopter is and what a Panem's fusional area is. So a horopter is basically every corresponding pair of retinal points will project into space as a single point. If we join all these single points together, what we get is a horopter. Now the dotted line which we can see in the front, this is the empirical horopter, and the circle that we see is the Wieth-Muller circle or the theoretical horopter. The Panem's area, it goes beyond the Wieth-Muller circle as well as comes behind the Wieth-Muller circle. And within this Panem's area, we see fusion. Beyond, we see uncrossed diplopia. Within, we see crossed diplopia. Now, before we go to test for evaluation of stereopsis, we need to understand this big confounder, monocular cues. Now, how do we appreciate a painting? It's quite similar. We appreciate it with a very beautiful interplay of shadows, light and darkness, relative position with respect to a reference line, like here we can see with respect to the horizon, and of course, an interposition or an overlay. So coming to evaluation, there are 2 conditions. Both the eyes must be dissociated, and second, each of the 2 field targets must contain elements imaged on corresponding retinal areas. So first we have the qualitative test. With the help of a synaptophore, strictly a synaptophore is actually used for measuring the ocular deviation and for fusion and simultaneous perception rather than stereopsis. And the pencil test, which is done in the OPDs. So in this, a patient with stereopsis will be able to perform this test with both eyes open, but not with either eye closed. Coming to the quantitative tests, the more important tests, now we have the vectograph tests. Now in these tests, what happens is that simultaneously images are presented to both the eyes with a different degree of retinal disparity. How is this achieved? This is achieved by using Polaroid glasses. It's achieved by using red-green spectacles. It's achieved by using laminations that have embedded cylindrical lenses, and of course, with the help of different thickness of plates. So this is the most commonly used Titmus fly test, in which the patient is asked to grab the wing of the fly, and then we proceed to the more fine stereoacuity tests. And of course, we can quantify it by using different retinal disparities or by increasing the distance from the patient. Now, this is the random dot test. Now, these remove monocular cues, so they're more accurate. We have the random dot E test, which uses a stereoscopic E. Then we have the TNO test, the second one right here, which uses stereoscopic shapes. After that, we have the Frisbee test and the Lang test. Now, what these tests are used for is for children, because they don't need Polaroid glasses or red-green glasses. So children are better able to cooperate. And students, so in the next class, we will look at the practical applications. What are the conditions that affect stereopsis, and what are the various vision therapy tests? So thank you very much.
So thank you, Dr. Gargi. So now over to Mahesh sir. He was your student, so he will ask some doubts.
Good afternoon. I am not too sure what exactly is stereopsis. Why is it necessary?
Sir, so stereopsis is often confused with depth of perception. Depth of perception is not really stereopsis. What is depth of perception? I am assessing, you are sitting here, I'm assessing ma'am sitting there, that is depth of perception. But with one eye closed also I can assess that. But in stereopsis, we get a very three-dimensional view. And this is achieved by giving the image to both the eyes at a slightly different angle. And how I have explained. So do you want me to explain the retinal disparities again?
No, I'm fine, thank you.
Okay. So let's have the scores for the second person from Team Assam. 9 and a 7 and a 7. 9, 7, 7. So that's about 14 plus 9, 23. So Team Assam scores 22 plus 23, which is about 45 marks. Let's see. Let's go to Chandigarh now. Dr. Hitisha? Yeah, you can start. Dr. Hitisha Mittal. You will be talking about anti-VEGF in PDR, right? Dr. Hitisha, you'll be talking about anti-VEGF in PDR.
I want to use the hand mics.
And Abha Gupta is ready? So you'll be talking about topography in keratoconus. Yeah. Can you put the timer on? Yeah. If you're using that mic, you can give this mic to them. Are you using, which mic are you using?
I'll use this, sir.
Okay. Slides on, please.
Good afternoon, everyone. I'll try and attempt to teach you a little bit about anti-VEGFs in proliferative diabetic retinopathy. We all know PDR is an advanced stage of diabetic retinopathy with active neovascularization, where there are certain features which have been given by the diabetic retinopathy study as the high-risk characteristics. Now, these HRC PDR patients are prone to certain complications like vitreous hemorrhage, subhyaloid hemorrhage, tractional or combined retinal detachments, and neovascular glaucoma, all of which can result in a severe vision loss in our patients. That makes it all the more important for us to understand PDR and how we can manage these patients. Now, the main culprit behind all these dreaded complications is the vascular endothelial growth factor, which results in new vessel formation from pre-existing vessels in the retina, increases the vascular permeability, and causes inflammatory cascade activation, resulting in all those complications that we discussed. Now, how do we deal with this? There are a variety of anti-VEGFs available in the market. To name few, bevacizumab, ranibizumab, aflibercept, and brolucizumab. no need to get scared of this table. We don't need to cram it all up. We just need to be aware that there are certain anti-VEGFs available and they inhibit the VEGF-A isoforms. Aflibercept has an added advantage of inhibiting VEGF-A, VEGF-B, and placental growth factor. Now, there are certain studies related to PDR which we need to be aware about. I know it's a dreaded thing to mug up in retina, but I'll try to make it simpler. There are two important studies. One is the diabetic retinopathy study, and the other one is the DRCR network. DRS basically told us that we need to do a PRP for the HRC PDR patients, but it was done prior to the advent of anti-VEGFs. The DRCR was the newer studies which evaluated the role of anti-VEGFs in PDR, and there are two protocols, Protocol S and AB, that we need to briefly know about. Now, Protocol S compared the PRP with ranibizumab in PDR patients, and at 2 years, it told us that ranibizumab has better visual outcomes. But when the same patients were followed up at 5 years, it told that both the groups had comparable visual outcomes. So from this, we can remember that ranibizumab is non-inferior to PRP in PDR patients. That's all we need to remember from this one. Protocol AB investigated the role of aflibercept with PPV in PDR patients who had vitreous hemorrhage. And they found that both had similar visual outcomes at the end of 2 years. So from this, we need to remember that aflibercept and PPV are comparable for patients who have vitreous hemorrhage secondary to a PDR. Now, based on this, what are the indications for anti-VEGF use? It's neovascular glaucoma where PRP cannot be done, or a PDR with comitant diabetic macular edema, or a lasered PDR with active neovascularization, and a treatment-naive PDR where we can give the patient an option of alternate treatment other than PRP. We can also use it pre-operatively to decrease intraoperative bleeding and make the surgeon's life a little better. And we can also use it intraoperatively. It depends on the surgeon's preference if he sees active NVDs, NVD, or NVEs in an unlasered PDR patient. Now, this is an example of a TRD involving macula, and we can see there is regression of those massive neovascularization. This is a patient with DME, and we can see there is reduction in the DME post-injection. So we should keep in mind certain complications related to these anti-VEGFs, which includes cataracts, endophthalmitis. It can also cause crunch phenomenon or stroke and MI. So it's contraindicated in patients with MI or stroke in the last 3 months. Now, how do we make sure we do not land up with complications? Rule out active adnexal infections in the preoperative period. Make sure the blood sugars are controlled. You should use povidone iodine prior to injecting. It should be given under sterile conditions, and there should be no talking while giving the injection because we want to reduce the risk of endophthalmitis. Thank you.
One of the students can ask the question, ask a doubt to the madam.
Ma'am, I have a patient who is sitting in front of me with PDR. So
Yes.
what do I suggest? Do I suggest laser or do I suggest injection?
Sir, I'll ask him, can he follow up with me frequently? If he says, I cannot come, I come from a remote area, we tend to do a PRP on the same setting because these patients get lost to follow up. But if the patient says, I can follow up, doctor, I can afford the injections, then we can get blood sugar testing done, and we can give him the option of anti-VEGF as well.
Is there any advantage of having an injection every 6 weeks in the eye?
Sir, the patient's visual fields are usually preserved when we are not ablating
You
the
only said that
pentacell retina.
the visual field is the same after 5 years.
At 5 years, yes, sir, but in those 5 years,
5
also
years,
the
you'll be
patient-
able to see better inside. Okay, thank you.
Okay, so let's have the marks for Hitisha. A 9 and a 9 and an 8. That's impressive. 9 and
Thank
a
you so
9
much,
and
sir.
an 8. Okay, 18 plus 8, 26. Next, we will have Dr. Abha, who will be teaching us topography of keratoconus. Over to you, madam.
Good afternoon. We'll be learning today the uses of topography in keratoconus. Coming on to the history, topo means surface and graphics means writing. So we started our journey in 1619 from shiners comparing the reflection of window panels on marble to a long journey to 1881 where we finally got this machine called keratometer by Javel and Syortz, which simplified the anterior corneal curvature mapping. So corneal topography is a non-invasive imaging technique for mapping surface curvature and shape of the anterior corneal surface, which basically measures the Purkinje 1 images of the Placido disc, which are equal in a normal cornea. However, in an abnormal cornea, the Meyers are usually closer in the areas of the steeper cornea. Now, what is the difference between topography or tomography? The topography essentially measures just the anterior corneal curvature. And now that we know that most of the diseases like keratoconus start from the posterior cornea, we have a new principle called elevation-based tomography maps. The elevation-based tomography maps can be measured by slit scan, Schlimm-Flug, and a high-resolution anterior segment ASOCT. These are the representative images of all three types of tomographic maps. The tomography maps are usually color coded with the warm colors of red and orange, neutrals of green, and cool colors of blue and purple. In the axial map, the warm colors usually denote a steeper cornea. In the thickness map, it denotes a thinner cornea. And in an anterior and posterior elevation map, it denotes an elevation above the best fit sphere. However, it is important to remember that these colors are variable and the parameters can be set according to the observer. These are the various topographic images which were described by Rabinowitz or Toll, and just a gentle reminder on the last image, that is the asymmetric bow tie, which is usually present in 0.15% of the normal population. However, presence of asymmetric bow tie should give you a suspect that the patient might be having a keratoconus. So what is keratoconus? Keratoconus is a Greek word which means cone of cornea, and it is a bilateral asymmetric progressive thinning of the cornea which leads to blurring of vision. The topographic features of keratoconus include high central corneal power of more than 47.2 diopters, any inferior and superior asymmetry of more than 1.2 diopters, asymmetric astigmatism more than 1.5 diopters, any progressive thinning or irregularity in the thickness map. This is a representative Schlimm-Flug pentacam image. So we'll see that in the axial curvature map, there is a steepening in the inferior temporal axis with a K value of 57.2, and there is an inferior superior asymmetry of around 3 diopters. Similarly, in the corneal thickness map, there is a central corneal thinning and the thinnest pachymetry is around 381. Similarly, in the anterior posterior elevation map, it is easily visible that there is a corneal elevation above the best fit sphere. So the question is, when and why do we need a topography? We need a topography to diagnose form thrust from subclinical keratoconus. Well, now what is form thrust keratoconus? Form thrust keratoconus is a clinical manifestation of keratoconus in which we have a clinical keratoconus in one eye and a completely normal other eye. Whereas in subclinical keratoconus, we have topographic features of keratoconus with no clinical finding and a best corrected visual acuity of 6/6. It can also be used for assessment of progression of keratoconus, to assess the various treatment modalities we have, and to differentiate it from other diseases of the cornea. So the take-home message will be, to diagnose keratoconus, we require a good slit lamp examination. A dilated retinoscopy is necessary to look for scissoring reflex and oil drop reflex, and combined with topography and adjunctive tests. That is the key to diagnose keratoconic subtypes. But to diagnose keratoconic subtypes, it is important that you understand the spectrum of normal corneal topography to look out for any other subtypes. Thank you.
Thank you very much, Abba. Krishnadas sir, you can also.
No, I don't have a question, but just a suggestion.
Yes, sir.
Your presentation was excellent.
Thank you, sir.
But as a teacher, what you should try to be a little interactive, and you should always try to maintain eye contact with the students.
Okay, sir.
Your eyes were always on the monitor.
Thank you, sir.
I understand
The
time
topic was too
constrained
vast
and all
for
those
me
things.
to
I
cover, sir.
understand. I
Yes, sir.
understand.
Sorry.
Just a suggestion
Yes,
when
sir.
you want to become a good teacher.
Yes,
As
sir.
a student, it's all fine.
Yes, sir.
Okay. Right. Good.
Thank you, sir.
Yeah, let's have the marks for Abha. Hitisha had great marks. What about Abha? 7 and a 7 and a 6. That makes it 20. So Chandigarh gets 46 marks as opposed to Assam's 45. Okay, let's move to Tamil Nadu. Who are the Tamil Nadu team? Samir Chaudhary and Deepika. All right. So who is presenting first? Ladies first? No. Okay. Fine. So Deepika is presenting lateral orbitotomy. Are you teaching us lateral orbitotomy today?
Yes, sir.
Wow. Okay.
Good afternoon, everyone. Today, let's discuss regarding lateral orbitotomy. Let me throw you a case. Here is a young lady with infranasal dystopia, and there is fullness in her superolateral aspect of her orbit. And here is an imaging showing a well encapsulated homogeneous mass in your superolateral aspect of your orbit, which is corresponding to your lacrimal gland region. And clinically, it might be a benign lacrimal gland tumor. So, how do you proceed with this? So before that, let's have a quick recap of our surgical anatomy. So the lateral wall is the strongest and the thickest bone of all the 4 orbital walls. And it is formed anteriorly by your zygomatic bone and posteriorly by your sphenoid wing, the greater wing of the sphenoid. And your surgical spaces, you have your extraconal space, which is bounded peripherally by your periorbita and internally by your extraocular muscles and your intermuscular septum. And your intraconal space is the one which is bounded peripherally by your extraocular muscles and its septa. So how do we access these spaces? So orbitotomy is the surgical approach to the orbit, which is done commonly for any incision or excision biopsies of any orbital tumors, any orbital floor fractures, or decompression surgeries in your thyroid eye disease. So what are the prerequisites that we need before the surgery? Imaging. It's an invaluable tool before imaging to plan your surgery. We need all the sections, coronal, axial, sagittal section. And we need to have an adequate exposure, your surgical exposure, to allow a safe dissection. And we need to have bloodless field. The patient has to be stopped all the anticoagulants and aspirin before the surgery. And local hemostasis should be maintained throughout the surgery. And proper instrumentation, additional instruments that are used for bone removal surgery like a chisel, hammer, and mullet, everything should be kept ready. So there are various surgical approaches, superior, inferior, medial, and your lateral wall. But today we are going to discuss the lateral orbitotomy. So it gives a wide access and a more rapid procedure in case you're removing the bone. And it is relatively less complicated when compared to the other approaches, as there is no vital neurovascular bundle in your lateral aspect of your orbit. So it is commonly indicated specifically in the lesions which are in the lacrimal gland region or the lesions which are lateral to your optic nerve, which might be extraconal or intraconal. So the surgical approach starts with your skin incision. So the lateral orbitotomy was first described by Conlon in 1888. He made a curved skin incision which was opposite to your globe contour, and it was giving a disfiguring scar. And now this is of historical importance. Then came Berkey. He has modified the Conlon's incision to just a lateral canthotomy incision. Then we have the modified stellaride incision, a lazy S. Then an upper eyelid incision, which can be a complete or a lateral incision. Then the coronal flap incision, if you want to go deep into the apical lesions. Then now we have moved on to a scarless transconjunctival approaches. So let's quickly run through the surgical steps. Here I'm going to discuss the stellaride skin incision approach with a bone removal. Here you can see the skin incision has been marked. Skin has been incised, orbicularis. Then your periorbita is opened. The lateral orbital rim is exposed. Then the osteotomy. The orbital wall is removed. Then the periorbita is opened. Blunt dissection of the tumor is done. It is dissected. And we have to grossly examine it on the table. Then the periorbita is closed. Then the wound is closed in layers. We have to ensure a complete hemostasis and So this is the post-op day 1 picture with gratifying results. To summarize, we need to have an adequate knowledge of the anatomy, and we need to make a right choice, the right surgical approach, and we need the right...
We are over short time.
Yes.
Yeah. Let's have the judges' opinion and doubts and all.
So, ma'am, what neuroimaging would you do? Should we do CT scan or?
Yes, sir. So before any surgical approach, CT scan would be advisable because we need to know the orbital walls if there is any bony erosion. In case of any malignancy, we might be suspecting any bony erosion and extension. But at the same time, MRI is also really important.
My friend wants to know whether you lose MRI or CT scan.
Pre-op CT scan would be advisable, sir.
Yeah, can we have the marks for Deepika. A 9 and an 8. And I hope you will have some negative marks for the late finishing. Yeah, 7. 9 and an 8 and a 7.
Thank you.
Okay, good. We'll have Samir. Yeah.
Getting older is like climbing a mountain. You feel a little breathless. I want to go to the previous slide. Previous slide.
Samir, you will be presenting on OCT biomarkers of AMD.
Yes, sir.
That's a class.
Hi, sir.
Okay, yeah, fine.
Getting older is like climbing a mountain. You feel a little breathless, but the view is much better. Well, that is not the case for age-related macular degeneration. A very good afternoon to one and all. Today we'll discuss OCT biomarkers of AMD. AMD is an acquired degenerative disorder of the retina characterized by drusen's and/or pigmentary abnormalities associated and is the leading cause of irreversible loss of vision in the elderly. It is conventionally classified as early, intermediate, and advanced. The later is further classified as geographic atrophy and neovascular AMD. The advent of high-resolution OCT has completely revolutionized diagnostics in retina and opened the doors wide open for OCT biomarkers. As we all know, anti-VEGFs are the standard treatment modality in neovascular AMD, but however, due to the profound pathogenic heterogeneity, a suboptimal response is often received. This is where OCT biomarkers aid the treating physician in personalize the treatment for adequate disease control and minimize the treatment burden. Various biomarkers have been evaluated for AMD. To begin with, hyperreflective foci represent migratory RPE cells or activated microglia in the neurosensory retina and are a risk factor for progression of AMD. Intraretinal cystoid fluid are hyperreflective cystoid spaces in the neurosensory retina and occur following the invasion of ELM photoreceptor complex by the proliferating CNVM. It is the strongest predictor of the baseline visual acuity and the outcome. It is of two types depending on the RPE status. The first one, exudative, is the one where the RPE is intact and is associated with a good response to anti-VEGF. The one that we see in the image is the degenerative type where RPE atrophy is there and conforms to the opposite end of the spectrum. Subretinal fluid is an intriguing biomarker in the sense it is the only one which represents a positive outcome. It is associated with the perfuse vascular net, supplying the viable RPE, and is associated with an excellent response to anti-VEGF. Double layer sign represents the separation of the RPE from inner Bruchs, representing a pachychoroid spectrum. And if the separation is hyperreflective, it indicates PCV, which is a type of CNVM. Outer retinal tubulation are hyperreflective tubular structures which occur due to the circular rearrangement of the photoreceptors and which are supposedly to aid their survival and associated with a poor visual prognosis. Cuticular drusens are nodular thickening of the basement membrane of the RPE and associated with the RPE clumping and vitelliform lesions and progress to geographic atrophy and CNV. Subretinal drusenoid deposits, also known as reticular pseudodrusenoids, are associated with PR disruption and RPE alteration and a risk factor for macular neovascularization and geographic atrophy. There are three morphological types: dot, ribbon, and mid-peripheral, out of which ribbon is associated with the highest risk. CRORA, short for complete RPE and outer retinal atrophy, is associated with complete attenuation of photoreceptor layer, RPE, and choriocapillaris, along with a choroidal hypertransmission area of 250 microns, is associated with a poor visual prognosis. Two novel biomarkers promise an exciting future. Polarizing sensitive OCT uses light tissue interactions and depolarization properties of the tissue examined to allow for a selective visualization of RPE as seen in the image. The RPE is seen as the red line and the inset represents an irregular RPE. In conclusion, in conclusion, the OCT biomarkers aid in the prediction of disease progression and guide treatment response. And we have various new biomarkers on the horizon, something we should all look forward to. Thank you.
Thank you very much, Samir. Over to the students.
Sir, I don't know which is RPE, which is retina. So what are the things which you should be looking at if I were to see a patient tomorrow? So type 1 CNVM, type 2 CNVM, which is what in this?
So type 1 CNVM is the sub-RP CNVM, sir. And type 2 is between the subretinal space, is in the subretinal space. And type 3 is intraretinal, sir.
Okay, and like if I were to decide which patient to treat or not, what are the OCT things which I should look at?
So subretinal fluid is something, sir, which should always be treated for, and it indicates a good prognosis. The quantity of the subretinal fluid also correlates with the response. Whereas if we see ORT or outer retinal tubulations, which is often confused with fluid accumulation, it is something which should not be treated with anti-VEGFs, and it should be just monitored.
Sure. Thank you.
Okay, how many marks for Samir Chaudhary? A 7 and a 6 and an 8. So that makes it 21. So team Tamil Nadu gets 45. Now to Telangana. Over to Telangana. We have Anirudh and Prapi, right? Are we ready? Dr. Anirudh will be presenting subluxated crystalline lens. He'll be teaching us on subluxated crystalline lens.
Just a minute. Can I have a handout?
No, do you have a hand mic?
That's okay. It's fine.
If you use a hand mic, then you have to use the stage.
Yeah, that's okay.
Yeah. You're teaching a subluxated lens.
Yeah. Now, just how Ritik is moving up, down, ahead, backward, in this video, a subluxated crystalline lens is displaced from its original position within the patella fossa. The moment that it's displaced outside the patella fossa, we call it dislocation, something that all our examiners love to ask us. Now, I know that this is a very busy slide, but there are these many conditions associated with a subluxated lens, the most important of which is trauma. So in all patients who come to us with this condition, we need to rule out a history of trauma, following which we ask a negative history for all the conditions that you see on the left. Now, every symptom, every sign has a reason, and the most interesting sign or symptom that I saw in this was double vision, because these patients will present with a monoocular diplopia because half the light goes through the phakic portion and half the light goes through the aphakic portion. Now, the first examination that we do is a best corrected visual acuity followed by refractive analysis. And these patients usually present with a myopia or an astigmatism, the importance of which we'll see later. Then we make the patient sit on the slit lamp, and megalocornea is something that we see with Marfan syndrome. And then in the anterior chamber, we look out for cells and, more importantly, for vitreous. It is important to look at the lens position with an undilated pupil, and then in a dilated examination, we look at the status of the zonules. Now, it is common knowledge that the zonules are preserved in case of Marfan syndrome, and while they're usually broken in case of homocystinuria. Now, intraocular pressure gonioscopy is very important because these are a list of causes of glaucoma that are associated with a subluxated lens. And lastly, of course, the posterior segment in which retinal detachment can be seen both with trauma as well as with Marfan syndrome. Now, I know we are all ophthalmologists, but let's not send the patient away before evaluating him or her systemically. And we've been studying these systemic features associated with Marfan syndrome ever since high school. And these are a couple more. Now, one of the most important investigations ocularly is biometry. As you can see in the biometry above, the K1, K2 values are lesser than 40 diopters, suggestive of a flat cornea, which is most commonly seen with Marfan syndrome. And the second patient has normal K1, K2 values, but a significant astigmatism, which can be attributed to lenticular astigmatism. Now, we also sent for a 2D echocardiography for ruling out a dilated aortic valve, a urine spot test for homocystinuria, and most importantly, we checked the family and the siblings who've come along with us for screening because these conditions are associated with the family history. Now, not all patients with a subluxated lens require surgical management. Most of them do well with just refractive error, but they need to be monitored closely because in cases, especially with Marfan syndrome and homocystinuria, you can have progressive subluxation. However, these are the surgical indications. Now, if the lens is in the anterior chamber, of course, we have to get it out. Other than that, if there is a poor visual function not improving with spectacles, or in case of cataract, or if there is lens-induced glaucoma or uveitis, we need to go ahead with surgery. Now, the most important challenge that we see is that the bag is unstable. And so in this case, our Brahmastra will be a capsular tension ring. Now, this exerts a centrifugal force and increases the stability of the bag. But in cases when the subluxation is greater, we need a modification. And that modification is this eyelet there, the third eyelet, which is slightly more anterior. And this allows suturing of the eyelet to the scleral wall, giving more stability. Now, that device was quite big. So a modification called an Ahmed capsular tension segment was made, which can be slid into the area of greatest zonular weakness. And depending on the amount of subluxation, we can accordingly go with the procedures as listed above. Thank you.
All right. Any doubts? Yeah.
So, what if patient consistently complains of diplopia, but has a subluxate lens, but a clear lens, non-cataracted lens with Marfan syndrome? So, should we go ahead with surgery, sir, or how should we manage?
So, if the patient has diplopia, that probably means that the lens could be bisecting the visual axis. And in this case is especially an indication for surgery because the patient will have significant functional disturbance. So yes, in this case, we would go ahead with surgery.
Okay. Now for the, sir.
How do we do refractions in this patient?
We go ahead with a retinoscopy, but the refraction will be a little difficult because of the glow that we see, but then we correlate it with the biometry.
No, do we give him a minus power or do we give a plus power, sir?
So depending on the refraction that we...
You said it's bisecting. So which one would we refract?
So in case, yeah, exactly. That is a problem that we face even while during doing refraction. So in case it's bisecting the visual axis, that is a clear-cut indication for surgery. So I would say that we'd ideally go ahead with the surgery at this stage.
I'm going to be an ophthalmologist, and then why would I be worried if the patient has a aortic valve problem or if that like patient has Marfan syndrome? Anyway, I'm not going to treat that, right?
Yeah, but a lot of patients can come to us without visiting a physician first. So if we as ophthalmologists can pick it up that the patient could have Marfan syndrome and send them for an echocardiography, it possibly could save the patient's life.
But you're not going to treat the echocardiogram, right?
Yeah, we'll refer them to a physician after doing the investigation. Yeah.
Okay, sir, let's have the marks, please. A 9 and a 7 and a 9.
Thank you.
9 plus 9 plus 7. 24 marks. Prapi Chadda on high myopia. 20? 9 plus, oh. Okay. 9 plus 9 plus 7. 25.
Okay, good afternoon, everyone. Today I'll be taking you through Beyond Blurriness. My topic for today is high myopia. Now, why is it important? Because it is estimated that 1 in every second person eventually by 2050 are going to be myopic, because after the pandemic of COVID, we are going to have a pandemic of myopia. Just a fun fact which could be asked in your quiz is which country has the highest prevalence of myopia is Taiwan. The high myopia itself is a topic and is huge as ocean. And 4 minutes is just going to be a drop of water in that. So I have 3 objectives for today, and I'll be giving you 4 take-home points today. The first objective is what is the difference between high myopia and pathological myopia. So coming to our first objective. So in both high myopia and pathological myopia, you will have a diopteric power of more than 6, and axial length of more than 26.5, the thing that will differ is there will be no myopic maculopathy in high myopia, which will be present in the pathological myopia. And there will be loss of uncorrected visual acuity in the high myopia, but there will not be any, there will be loss of both uncorrected and best corrected visual acuity in the pathological myopia. Also, there will be presence of staphyloma, which will invariably make the high myopic patient a pathological myopic patient. Now, what happens is because of the thinning of the choroid, thinning of the RP, the underlying choroidal vessels are seen, which is why you will see tessellated fundus. And the other findings like chorioretinal atrophy, Laker cracks, first a few spots and everything, which will be seen in pathological myopia. At this point, I have a homework for you. You get treated disc, you get peripapillary atrophy. I want you to find out why does it happen and which amongst alpha, beta and gamma zone are important for high myopia. There will be lattice, which we all know in the periphery. I want you to focus on the second objective, which is very important, is how the eye controls its growth and what is its, how is it relevant in myopia. So there is a visual stimulus, which is defocus, which will cause retinal response, which will communicate with the sclera and ask it and causes remodeling of the sclera, and there's growth and growth and axial length elongation. This results that the defocus image comes to the focus. Same thing happens when the accommodation is not functioning well, which we'll see. So what happened is during emetropization, the eyeball is small, there is defocus of the image, the eyeball starts growing. At point, there is emetropization. But at this point, the peripheral rays are still focusing beyond the retina, which again triggers the eyeball to continue growing, which is why the peripheral defocus is an important aspect in prevention of myopia nowadays. So the risk factors, as we all know, is parental and hereditary, near work, accommodation problem, ethnicity, and the only protective factor which they have found out is outdoor activities. And there are systemic association with myopia, and we have to keep those in mind and not just look at the myopia. Coming to our third objective for today, which is the treatment option, there are various options available like spectacle, contact lenses, laser vision correction, ICLs, and refractive lens exchange. But the intellectuals solve problems and the geniuses will prevent them. So our armamentarium is atropine eye drops, bifocals, multifocal contact lenses, DIMS, and orthokeratoplasty. And to tell the patient to have a lifestyle modification like you advise in diabetics and hypertensive. So my mantra will be master, like understand it's a multifactorial thing, monitor them well, and manage the patient completely and not just by giving a single vision correction to them. Thank you.
Okay, Prapi. Are there any doubts?
And any effect of any color would, I mean, I had said that Dr. Mahesh Shanmugam sir from Bangalore had asked in the Viva, is there any effect of color on myopic progression? I don't know. Is there an answer?
I would have to read about that, sir.
Better way to say that you go and find out.
Yeah.
Do your homework.
Yeah, that is what you should have said.
You should say, oh, that's a great question, and I want you to find it out.
It's a good research question also. You can probably work on it.
Okay, how many marks for Prapi Chitta? 8 and a 7 and an 8. That makes it 25. 8 plus 8, 16%. No, 23. Okay. No, I think I am getting a little. Okay. Yeah, I didn't have breakfast and lunch. Okay, it's 23. So that brings Telangana to 48 points. Okay, so Assam and Tamil Nadu tied up at 45, Chandigarh at 46, and Telangana at 48. All right, next, coming to Chhattisgarh. We have two people, Samskriti Tiwari. Yeah, please. Samskriti Tiwari is going to teach us today about a new topic, cell therapy. Are we ready? Yeah.
Yes. A very warm good afternoon to everyone. Today, I'll be teaching you about cell therapy. As we all know, vision loss is a major social issue which affects the quality of life. Thereby, various studies are going on there in order to find out various therapies in ocular medicine. And one such therapy is cell therapy. So, what is cell therapy? It is a new world regenerative medicine which aims to repair the damaged cells or tissues by modulating the immune system. Of course, by using the stem cells, which are nothing but the undifferentiated cells that are present in embryonic, fetal, and adult life, which gives rise to differentiated cells. So, why these stem cells are the front benchers in this field of ocular medicine? Just because of their three properties, that is self-renewal, clonality, and potency. Now, we can divide stem cells into four, that is totipotent, pluripotent, multipotent, and oligopotent stem cells. Of course, out of which only specific stem cells are used in ophthalmology, like human pluripotent stem cells, which maintain their undifferentiated state for a prolonged period in culture, but can lead to formation of teratoma. Other stem cells are adult stem cells, neural stem cells, mesenchymal, bone marrow derived human adipose, dental pulp, RPE stem cells, and limbal stem cells. So how do we select stem cells? First, we have to decide whether we have to use the same eye or the fellow eye, or we have to use the patient's eye himself, or we have to call the donor. Now, once that is done, we have curated many techniques for stem cell therapy. First is transplantation, which can be used as cell suspension or over autologous sheet of cells, or using biomaterial patches, which targets our cornea, neural retina, or RP. Another such method is injection, which is still under study, wherein we inject intravitreal or subretinal stem cells, and which mainly aims to study in ARMD. Now, third is topical stem cell therapy, which employs hematopoietic stem cells, mainly associated with ocular surface diseases like dry eye or any sort of corneal injuries. Now, I want you to focus on this main blue box. Here, a breakthrough process occurs where we equated the bioengineering and the stem cell therapy, and we gifted the patient with scarred cornea a beautiful visual acuity along with cosmesis too. Now, in the field of corneal stroma and endothelium, various studies have said that stem cells are able to produce new collagen, which would be helpful in the patients of keratoconus. Similarly, in trabecular meshwork aspect, stem cells are very helpful in maintaining the IOP homeostasis. Then in aspect of lens, if we opt for minimally invasive surgery, we can preserve our lens epithelial stem cells, and thereby we can increase the visual axis transparency and decrease area of complications. Now, optic nerve stem cells can also promote axonal regeneration, and mainly we focus on retina. In 2001, US FDA, they allowed phase 1, phase 2 clinical trial to check the efficacy of subretinal injection of RPEs for dry AMD or Stargardt's disease. Similar one study was also allowed in June 2012 in phase 1, phase 2 clinical trial, where neural stem cells were used for AMD. Now, if we flip the other side of the coin, we will have some limitations for this stem cell therapy too, like immunological tolerance, oncogenicity, issue about tissue survival, and tissue retrieval, where we may face ethical problems. Now, we have opened this Pandora box. If we dig it more further into it, we may incorporate stem cell therapy with bioengineering and nanotechnology, where we can build ocular structures like trabecular meshwork or RPEs. Or we can also generate 3D structures. Like Nakano et al. Suggests that we can generate differentiated 3D ocular structures, or we can also transplant pre-polarized RPE. Same was suggested by Garzan et al., where anterior cornea was generated via tissue engineering. Thank you.
Thank you very much, Samskruti. Yeah.
Ma'am, can any of these be done in our place?
We have done, means in India, we have done, the simplest one was limbal stem cell transplantation, which we do it, and in minor surgeries like pterygium surgeries, we also do limbal stem cell surgeries, limbal stem cell transplantation. So optic nerve studies are still going on, so we don't have any substantial evidence and substantial therapy still.
Okay, can we have the marks, please? For Samskriti. 7 and a 7 and a 7. Uniformity. This is what is called uniformity. It's very easy for me to say 21. Yeah, now let's have Dr. Yamini. She's teaching us today a very basic thing, gonioscopy techniques.
So, a very good morning, respected judges and my dear students. I'll be teaching the topic gonioscopy techniques. So,
What's happening? It's not moving? Can we start it over again? Okay.
So sorry for the glitch, but we'll begin again. So a little bit of the history. Alexios Trantas used the word gonioscopy, where gonia meaning angle and scopion meaning to observe. So how does this work? The angle of anterior chamber cannot be visualized directly through the intact cornea because the angle structures undergo total internal reflection, meaning angle of refraction is more than angle of incidence. So if here in this case it is 46 degree, the critical angle is 46 degree. So when light passes from greater refractive index to lesser refractive index, and when angle of refraction is 90 degree, the angle of incidence is known as critical angle. So we'll change the theory. We remove this tear film air interface and it is replaced by tear film gonio lens interface. So principle of types of gonioscopes, direct gonioscopy, here anterior curvature of gonio lens is such that the rays are refracted. And so the light rays are refracted from the lens air interface. And in indirect gonioscopy, the light rays are reflected through the mirror present in the gonio prism. So the direct gonio lens, Kippe's gonio lens, which is the main diagnostic gonio lens, the image shows the Swan-Jacob gonioscopy examination under anesthesia was done here. So this is a 50 diopter lens, which is placed on the eye on the patient using a saline just to create an interface. After that, using an illuminator and a light source, both the eyes can be observed simultaneously. The other include Richardson, Schaffer, Leyden, Barkan and Thorpe. Indirect gonio, Zeiss 4 mirror, Posner's 4 mirror, Sussman, Thorpe are few others. So in this, the main thing is room illumination should be dim. The chin and forehead tilt shouldn't be present and it should be aligned along the lateral canthal line. So first we'll instill topical anesthesia in both the eyes, followed which will instill the viscous solution in the lens. Make sure to add no bubbles in it because it will distort the area. The slit beam should be 1 into 2 mm, not crossing the pupillary border, because that will induce pupillary meiosis, which will constrict the pupil and pull the peripheral iris away from the angle. So that cannot be a perfect investigation then. Followed by which the tip of the Goldman lens is brought here and inferior part is indented. This is the schematic of indirect gonioscopy with images used at 180 degree reverse images are seen here, but right-left orientation is the same. So main difference in direct gonioscopy, manipulation gonioscopy and indentation gonioscopy. There's erect and panoramic view in direct gonioscopy. There's minimal distortion of chamber of angle here and there's less magnification. There's smaller learning curve in manipulation type, and in indentation it differentiates mainly between appositional synechial angle closure. A coupling fluid is not needed here. In indentation gonioscopy, we directly indent in the center of cornea. So by indenting, we are pushing the fluid through the aqueous. So the aqueous is pushed outside and iris moves posteriorly. So now this moving will cause opening of the apposition. This can happen in appositional but cannot in synechial closure.
Yeah, I think that's the bell ringing. Your period is over. Yeah.
Oh, ma'am, can we do indentation gonioscopy with Goldman 3 mirror? Can we do that also?
So it is not that perfect. Indirect, the four mirror one is better.
Better, but 3 mirror also you can do indentation?
You can, yes. So the four mirror one is better for
You cannot.
So, Matt, if I want to start a general practice and I can afford only one gonio mirror, which would you suggest? General practice, I can own only one.
So the four mirror.
You suggest not loudly. You are teacher. You have to tell.
So
loudly.
the four mirror one.
You suggest 4 mirror. Okay, thank you.
Okay, so we have a 7 and a 7 and a 6, which makes it 20. Next, we have Yamini. Oh, you are Yamini. Oh, next is the Maharashtra team. Okay, next is the Maharashtra team. Come, 1 second. We'll have Ankita talking to us about failed trabeculectomy.
Yes.
All right.
So, hello class. Today, so if a patient comes to you and he needed trabeculectomy and you've done wonderful surgical job, but now the pressures are rising more than the preoperative level and you're feeling like a failure. Well, what does that bring us to? That brings us to our topic today. That is a failed trabeculectomy. Well, what happens when a trabeculectomy fails? Well, you cry first, but then secondly, you have to take certain measures. So what do? So what happens when there's a failed trabeculectomy? Well, there's persistent hypotony, where the IOP is less than 5 mm of Hg, and if the IOP is more than 21 millimeters of mercury, or if the IOP has not reduced by 20% below the baseline, we have to look for the next. So what now? You have to look for the signs of failing. As the first chance is the best chance, and you have to anticipate the failing trap. A second chance is never the same as the first, so you have to take actions immediately. So who is at risk? Well, a young patient or a patient who is on long-term use of glaucoma medication, anti-glaucoma medications, because the surface is already bombed because of the medications, the ocular surface is not that good. So excessive inflammation because of uveitis or trauma or any other neovascular glaucoma, and of course the subconjunctival hemorrhage. So what are the signs of failure? Well, there can be rise in IOP with deep anterior chamber, and you have to look for the appearance of the bleb. How does it look? It might have corkscrew vessels, or there can be a thick opaque walled bleb, or there can be a flat or very elevated bleb. So what are the causes of failure? Does anyone know? What is ab externo? What is ab interno? Well, let me tell you. Well, ab interno can be because of tenon cyst or encapsulated bleb, or it can be because of flat or fibrous bleb. And ab interno can be because of iris plugging ostium with ciliary body, vitreous, or a blood clot or fibrosis. So what do? We have to confirm the patency. Well, my colleague Dr. Yamini just taught you how to gonioscopy, so I'm not going to teach you that again. But you have to check for how is the ostium. If it is blocked, then you have to do YAG opening. If it is patent, then of course you have to look for the scleral flap to see if there's any fibrosis there. So what do? We have to salvage the flap. We have to salvage the failing bleb. So you can do digital ocular massage, you can do suturolysis, you can remove the releasable sutures, you can restore the bleb function or do bleb needling. We'll see this one by one now. The ocular digital massage, it can be done through upper lid or lower lid. Usually when we do it at the slit lamp, 7 to 10 days post operation. And if you see a flat bleb, you can just press it behind the bleb and see if the bleb is forming. You can, of course, ask the patient to do it at home through lower lid. If there's releasable suture, you can, of course, remove it. If you have laser to remove the suture lysis, you can do laser suturolysis. And 5-fluorouracil antimetabolite injections can be given behind the bleb. It can also be coupled with needling, which can be done ab interno or ab externo. And ab interno can be done using a Gower spatula. Then these are it can be coupled with 5-fluorouracil. Even if there's a progressive bleb failure, the revision surgery of the trab can be done, or a retrab at a different site can be done. So these are my take-home messages. I hope you've learned from this class.
Okay. Any doubts? This class is full of doubts all the time. Yeah. All doubting people. Yeah.
That means they are attentive in the class.
Very good. Yeah, you have some questions? No. Then
They've
can we have
understood.
the marks? Marks for Dr. Ankita. 9 and a 9 and a 8. Very good.
Thank you.
That would be 26. Can we have the next person? Neelambika, who will be teaching us newer techniques for population-based screening for eye disease.
Okay, I hope nobody is in a food coma after the lovely food that was there today. So, did you know that the Indian population has actually reached 1.4 billion? And we as ophthalmologists suggest 15 out of them for 1 lakh of patients, which is why we need newer techniques for population screening. Right? What is screening? It is basically detection of unrecognized disease in apparently healthy or asymptomatic population with using tests which are easy, which are rapidly done, and which are cost effective mainly. So screening should be done for mainly causes which are preventive, which cause preventable causes of blindness. So it can be done for ROP, for refractive errors, for amblyopia, for in small children, or for adults like in diabetic retinopathy to screen for cataract, glaucoma, or refractive errors. So to start with, let me take you through the history of screening. First of all, the doctor used to go to the periphery and they used to use the torch and the visual acuity charts and used to check individually. This was the face-to-face screening, after which with the advent of the AR machines and the IOP machines, it became much easier for the doctor to screen in a better way. And now, coming to the telemedicine age, there is a teleophthalmology, which after the COVID era has gained a lot more importance. So coming to this, it is a branch of telemedicine, and through the telecommunication technology, we are trying to reach a wider population. We are trying to reach an unserved rural population and an underserved urban population. So an excellent example of this is this Karnataka Internet Assisted Diagnosis of ROP. This was the first large study which was conducted, in which the non-physicians were trained, and they were the ones who went to screen the preterm baby. And they checked and they graded these patients, and whatever was the results were found were through a software. They were sent to the Narayan Netralaya, to the main center, and the consultants checked it. So this was a very highly successful study that was there. Another use of the fundus photography is for screening of diabetic retinopathy, and other such screenings may need further evaluation. So coming to the main hero which is there, which is artificial intelligence, and it has much potential. This is one of the ways in which there is self-learning, and this, by feeding it more and more data, we are going to make it smarter day by day. So this is our child right now. This has to grow up. This is just in the baby phase. So what we do to teach it is we collect a multi-center data, we do the quality assessment, send it for processing, and annotation is done by the experts, followed by which suppose we have a data for retina, the anatomical region-wise division is made, and slowly the mass screening program is developed using the urgency determination along with disease probability, after which this algorithm performance is then sent out for real-world validation. Coming to an example of a digital health platform where the patient visits a screening camp and then after the screening in 5 to 10 minutes he gets the result, or it can be referred to a optometrist or an ophthalmology later. So the diseases that can be managed is diabetic retinopathy, the glaucoma, the CD ratio, the chronic eye diseases, as well as the ARMD. Even for ROP, AI is a very good tool, as well as for dry eye. So the limitations of AI include digital privacy, which is a big problem, and especially in developing countries like India, the cost effectiveness. So as you can see over here, I hope this is our future in the next 10 years. And one of you students, I want, the future lies in your hands, and somebody should develop much better screening tools so we can reach each and every one. Thank you.
That's very good.
You said AI is AI a hero or a villain? There are a lot of.
There is always two sides to a coin. So we can call it it depends on who uses the technology. So if we use it, if we have proper way of using it, and if the privacy is properly kept into account, then I think it could be used in a very good way, and it could reach everywhere. So it could be a very helpful tool.
So can we have the title of the class was Newer Techniques for Population-Based Screening. Can we have the marks? So all the presenters have presented. This is the last 8 and an 8 and a 7. Okay.
Mahesh always gives minus 1
plus 8 plus 7 is 23. So I think now, my dear teachers, I think it must be a good time for you to, each of you, to just tell a bit about these teachers who have taught us and how they can improve on their teaching.
So first of all,
By the time I will compile the marks.
I can't believe that they have been given topics just last night.
12 o'clock in the night.
Absolutely amazing. I mean, you have to give a round of applause to all of you. Amazing. Absolutely amazing.
I think there is one more thing. Each of them had mentors. Kasturi Bhattacharya was the mentor of Assam. Can you tell me the mentors for each of you? Can you tell us?
Yeah. So a round of applause for Dr. Rima Bansal, Dr. Kasturi Bhattacharya, Dr. Muthukrishnan, Dr. Siddharth Dakshit, Dr. Nidhi Patwardhan, and Dr. Amrita Verma. Well done. I mean, this is an amazing. Few suggestions. I mean, since this is a competition, there are a few things that are looked at critically as to how you made your slides, whether you acknowledged what kind of pictures you used. We understand that a lot of times you cannot use your own pictures, but if you can use your own pictures, it really makes an impression. This was done, and I know this has been Gopal's initiative, so you have to have a round of applause for him as well. That this he has been doing for last many years. And there was, I think, a Kerala team which won in Patna, and those guys were like, they were using the stage, and they were more like a rock star, and that's what probably is expected. This was not really a test of knowledge, but more like how you presented the knowledge that you acquired in last 12 hours. But well done, all of you.
I agree with Rashmin. If we were to score your knowledge, your speed of preparation, only few hours left, and the way you assimilated, prepared, and presented was just excellent. But teaching skills is much more than that. As I said, you need to really converse with the audience, which are students, if you want to strike a chord with them. That's what some of you did very well, and some of you just presented very well. That's what, if it was just a didactic lecture, it's fine. But teaching is not all that. It's all about how you can really connect with the audience, which are your students. And your students, you are expected to be a generation ahead of the student. And you're all expected to be the teachers of the future. And you also, again, the major issue has been the time. So apart from didactics, what other new innovative teaching skills can you adopt is a question. This is not for the competition. It's totally different. But when you want to take up teaching as a profession, which I'm sure many of us will be doing in institutions, in government medical colleges, many of us will be doing teaching. And it is our responsibility to ensure we prepare the next generation, just as your teachers have prepared you for a wonderful future. You need to really innovate your teaching skills so that you can connect better. But again, congratulations to all the mentors and the mentees for the wonderful job you all done.
Yeah, congratulations to all of you, because like I barely utter a word at the level when you were, like at whatever level you are, when about 30, 40 years back. A great confidence with which all of you presented. As Dr. Krishna was mentioning, there's a slight confusion, I think, because like it's more like presenting in a conference rather than a class. So that's where the issue came up. So you need to connect with the students and then probably take the knowledge a little notch down so that it's easily understandable. That's the only thing which was lacking in some of you, but then wonderful at your age to do this kind of a job. Congratulations again.
So that's from the mentors, the actual big teachers. Congratulations to all of you. Can you have this laptop on screen, please? This laptop on screen, please. Yeah. So we have the marks. So we have Assam and Tamil Nadu with 45 marks each. Chandigarh has a 46. Chandigarh has a 46. Telangana has a 48. And Maharashtra tops with 49. Big hand to Maharashtra. As far as the best individual teacher of tomorrow is concerned, we have Dr. Hitisha Mittal from Chandigarh, who scored a 26. And we have Dr. Ankita, who scored a 26 again from Maharashtra. So you will get tied up for the best teachers of tomorrow. And let us all part. It's about 4 p.m. now. We have time to go to the general body right now. So we should all part by thinking that the future of ophthalmology is secure in the hands of these young teachers. Thank you very much. Thank you very much, judges. Thank you very much.